Welcome to the webinar, sponsored by Clearly, Why Atherosclerosis is All That Really Matters. Today we'll be having Dr. Paul Knaapen give his lecture, The Utility of Coronary Atherosclerosis Imaging to Guide Coronary Intervention. We also have Dr. Jay Earls joining us from Clearly. He'll be giving a presentation at the end.
Thank you, Claire, and welcome everybody to the jointly sponsored webinar today. I'd like to for those of you who've been here before, you know, we'll do about a 25-minute lecture followed by some Q&A. So if you have questions, you can put them in the chat during the lecture, and then Dr. Knaapen and I will address them after he finishes. And then once we're done, I will do some guided case review and within the Clearly software. So that being said, I'd like to introduce Dr. Knaapen, who's professor of cardiac imaging and intervention at in the Department of Cardiology at the VU University Medical Center in Amsterdam. Paul, thank you so much for being here today and for helping us with this series.
Well, thank you, Jay, and it's a kind introduction and a wonderful introduction, and I'd love these endeavors to keep the process going while we're working within the field of the COVID era and doing these things online. I have nothing to disclose pertaining to this presentation. So as a way of introduction, I would like to state that obviously this is a CCT intro, that we know that CCTA has proven to be an excellent tool to rule out coronary disease, but not as much to rule in coronary disease. And from an interventional point of view, it's very interesting to see where we're moving now in the next generation, if you will, having ruled out coronary CT for coronary artery disease. But if you've ruled in, then what's next? So the anatomical features revealed by CT may guide you to help in intervention. And I am myself as an interventional cardiologist, I'm very interested, obviously not as much as in the rule out, but in the rule in theory. And we know that we have now a lot of patients who have been post-revascularization and where CT may still be of interest. So this is uncharted territory, which I think we need to explore. So back to the baseline theory that we used in the last century or so. We used to have functional imaging to determine whether or not we had obstructive coronary disease with myocardial perfusion, dopamine stress, exercise EKG. All of that was very important. And then we decided whether or not a patient was going to the cath lab. So this was basically the beginning. Abnormal ischemia test, you went to the cath lab. And then a little over 15 years ago, we had this anatomical feature where the gold standard of invasive coronary angiography has been replaced by non-invasive coronary angiography. And this is very interesting because now we're at a split point in time where we need to decide what are we going to do for which patients. And the most interesting feature of this is that they're completely different. Whereas the anatomical features are very good predisposed with CT-based imaging, and the functional imaging is very well predisposed with SPECT or with MRI or with PET, whatever. So these imaging modalities are pretty much complementary as they are competitive. So for which patient should you choose to go to the cath lab for what situation? Then this is a very difficult situation to be faced in when you're faced with the outpatient clinic. Because we know that if you ask CT first, and this is a very old slide, but I use it all the time, that this patient obviously has severe coronary disease based on CT imaging. High calcium load, near total occlusion of the LAD, high-risk patient. But in the cath lab, he has nothing. And we know this from the fact that there's only a crude correlation between diameter stenosis that we find in the cath lab and that we find on CT-based imaging. And this is due to a lot of artifacts, blooming artifacts. And this is a slide from 2005, but these are still problems that we face today. So we know that CT is a rule-out imaging technique, but not a rule-in imaging technique. So if we take a look at the guidelines based on all these sort of imaging techniques and what we know, we tend to rely on intermediate likelihood of disease. So if you have a low intermediate likelihood of disease, you go for coronary CT. If you have a high intermediate likelihood of disease, you go for ischemia detection. On the other hand, this is a very difficult process because how are you going to determine likelihood of disease? And we know from major trials like the PROMISE and Scott Hart and whatever, that simply we as physicians are not able to detect likelihood of disease all that much based on age, sex, and anginal symptoms. So that's why a couple of years ago, we decided to conduct a Pacific trial, which was basically a trial based upon the fact that we tried everything in everybody. So we did CT, we did SPECT, we did PET, and we did invasive coronary angiography with fractional flow reserve, which is the gold standard for revascularization, and had this stringent protocol, and to find out what the results were. So Pacific basically meant each patient without known coronary disease had either CT or they all had CT and SPECT and PET and invasive coronary angiography. And these were basically the results. Either you could, on the left upper hand panel, have a lesion in one coronary artery. You could have like ischemia with PET or SPECT, and you could have an FFR that was below 0.8 as a threshold for revascularization. Or you could have mismatches, or you could concordant, discordant. It didn't really matter, but we tried to choose what was the diagnostic yield, because we know the diagnostic yield of invasive coronary angiography in undetected patients is about only 30% for obstructive coronary disease. So this is the paper, and what we found out that if you did PET up front, that had the highest diagnostic yield, and that SPECT and CT had pretty much the same diagnostic yield. Obviously, PET is not available in like the majority of patients that we refer to, nor do you get any anatomical information. But the most important thing is that the accuracy of CT and SPECT were the same, like around 75%. But more important is that the hybrid combination of CT and or SPECT with an anatomical feature did not increase the diagnostic yield. And the diagnostic accuracy of these two imaging modalities were completely different. CT had an extremely high sensitivity, meaning it's a rule out, and SPECT had an extremely low sensitivity, meaning you miss a lot of patients. So if you're gonna get a patient who presents you with chest pain, if you're gonna do a CT, you're likely to overdiagnose, and if you're gonna do a SPECT, you're likely to underdiagnose if you take fractional flow reserve as a gold standard. A lot of people then ask, well, what about these new sort of computational model algorithms like FFRCT to enhance the diagnostic accuracy of FFRCT based on CT? Well, This has been around for over a decade now, and this is pretty much a game changer, where we see now that based on anatomical features, you can compute whether or not your FFR is going to be positive or negative. These were the early days. Then we had 3 major trials. This is what I call the evidence slide: the governor flow, the FFRCT, and the NXT, each with new iterations of FFRCT with mixed results. But the last results were that the NXT trial, published by Norgaard in 2014 in JACC, proved that if you add computational software to basic CT imaging alone, that you can enhance the diagnostic accuracy to send patients to the cath lab. However, this was still uncertain at that time because it is selected sites, selected patients, selected scans, and everybody knows that this is not necessarily reproducible for every site in every center. We also know that based on some reference trials and some meta-analysis published by Denat, who is my former fellow at the University Medical Center in Amsterdam and who trained with Jin Min, that we know that sensitivity and specificity of MRI and PET seems to be the highest, whereas the rule-out rate of CT is potentially high, but again, the false positives are high also. But at that time, when you included FFRCT, it seemed to become pretty close to functional imaging alone. And when we take a look at the coronary lesion, we tend to focus on what's the ischemic threshold. Is there a benefit of revascularization? Is there a benefit of placing a stent or do bypass surgery? So not as much just as seeing if there's coronary disease, but is there a benefit of sending them to the cath lab? So we ran a sub-study of the Pacific trial, which basically meant that we did all the patients, the 200 and some, who had all the functional testing also for CT coronary angiography, but also with FFRCT. And the results were actually quite surprising because the blue line means that FFRCT has the highest diagnostic accuracy. So this basically changes the paradigm in which we say, okay, we need to start selecting on pre-test likelihood. No, there's no pre-test likelihood. If you have symptoms and you have somewhere in the intermediate range of coronary disease, you should have a CT first. And if it's positive, you should have it functionally tested by whatever means, in this case, heart flow FFRCT, which has the high diagnostic accuracy. The problem with this trial is that only 75% of patients had full analysis and only 83% of patients had full coronary per vessel analysis. So there's much to be gained in the CT world to get functional analysis based on image quality. And image quality is driven by low heart rate, scan quality, obviously field of expertise, but it's important because that's much lower than what we're used to in functional testing. But one more important thing to say about these issues is the fact that CTCA goes beyond luminal angiography, because it also tells you something about what the plaque features are. And this is a slide from Jin Min telling you that you cannot only tell whether it's calcified, non-calcified, whether it's positive remodeling, spotty calcification, and everything. So CT goes beyond just angiography alone or FFRCT alone. And we know this from a very long time already, placed by the group of Jagat Narula, that adverse plaque features do matter. And these are things you cannot get out of an angio, invasive angio, and you cannot get out of functional testing, like positive remodeling, non-calcified plaque volume, spotted calcification, low attenuation plaque, and all these features tend to be of prognostic value. And they even ask you the question, are they of ischemic value, and do we need preemptive treatment of these kind of plaques, medical or invasive? And this is a very interesting study published in European Heart, which is an NXT subanalysis, saying if you have the CT alone, but if you add all those features like plaque features, you can do a much better job in predicting what is going to be an ischemic lesion and which patients should be referred to the cath lab. So we have now all this information. CT alone, if it's negative, it's negative. But if it's positive, look at the CT scan. What are the plaque features? What is the FFRCT? Should I refer this patient to the cath lab? Should I do intervention? These are all very important questions that we need to address. This was one of the incentives for Jim Min and colleagues to run the Credence trial. 618 patients with intermediate likelihood of coronary disease who went through several types of testing. But with CT, it was very important to realize that if you take a look at model 1, which is just stenosis severity, and model 1 and atherosclerotic plaque, or model 2, which added FFRCT, that they have all had incremental value. So it's important. But I think the most important thing of this trial was that if you take a close look at your CT on its own, beside just the plaque severity, look at the additional plaque features, that you can come pretty close to the computational fluid dynamics features that we have with FFRCT and competitors alike. So basically go beyond looking at plaque stenosis, also look at how does the plaque look like and what could be the hemodynamic consequences. We checked it in Amsterdam in terms of prognosis. We have this PET-CT camera, which can detect ischemia with positron emission tomography, as well as plaque features and stenosis with the CT camera. And basically, pretty much in a 10-year down the line prognosis element, basic features. If you have a stenosis, you're likely to do worse. If you have ischemia, you're likely to do worse. If you have additional plaque feature, you're likely to do worse. But the most important thing is what all these things add. And the most important thing is that ischemia is important. CT angiography, plaque burden is important, but also plaque features are important. So take a look at all these features together and you get a more comprehensive view on what you'd like to see. Then you come to the cath lab, because once you've determined the fact that these patients have ischemia and obstructive coronary disease, how are you going to send them to the cath lab? Just for diagnostic angiography? I don't think so. This is work by Max Opolski, who worked with us in Amsterdam for a year or so, and analyzed all the CT angiography that we had and analyzed from what place we should stent. So what is the lesion length of the plaque? What is the diameter of the plaque, and how should we stent it? And this adds tremendously to the cath lab. This is me with a Google Glass, having superlay over the imaging techniques of the lesion length. And now we're going into the cath lab not to do a diagnostic angio and to do ad hoc PCI. No, we know the angio is going to be obstructive, and we know we're going to have to place a stent. And now we also know what the stent length and diameter is going to be. And this is a real step forward, because we also know that restoration of fractional flow reserve by stent placement is restoration of flow. This is also from our center, where we computated what the delta fractional flow reserve was in the delta coronary flow reserve as measured by PET. And if you can compute this on baseline with CT coronary angiography, then you can refer this patient either for no intervention, intervention by stent, or intervention by coronary bypass surgery. And so these are all very important types of decisions for your patient making. And this is where HeartFlow introduced the virtual stenting concept. Now you have the CT, now you have FFRCT, but you can also place a virtual stent and see whether or not that's going to be of benefit to your patient. On the left-hand side, you see a lesion. On the right-hand side, you see a virtual stent, but you also get information about whether or not that's going to be advantageous to your patient in terms of getting a significant increase in flow / FFR. So this is a slide I obtained by Charlie Taylor, obviously commercially driven by HeartFlow, but I'd like to show it anyway because it gives a comprehensive view on the left-hand side, 2 types of lesions and what you can obtain by virtual stenting. On the right-hand side, whether you place 1 stent, 2 stents, what size of stents, and whether or not that's going to be a beneficial approach. So this is actually where we're going right now, from just having a CT and having obstructive coronary disease and sending your patient to the cath lab. No, sending your patients to the cath lab and saying whether they have obstructive disease or no is not relevant, but if you place a stent, that's relevant. We have studies dating back to 2014 saying, okay, you can sort of predict what virtual stenting is going to be. This worked pretty well. We did pretty much the same in the sub-study of the FFRCT in the Pacific trial, trying to use the FFRCT planner. This has been published in CCTA in 2020, not so long ago. I think this slide shows it all. It's still a bit of a beta version. You can sort of predict what the FFR is going to be after you place a stent, but it's not all that accurate yet. On the other hand, I think this is a good step forward in terms of getting the technology to improve whether we should or should not do interventional cardiology in this type of patients. Important slide is by Colette from the group of Serraus on the Syntax 3 trial, who compared whether you actually need patients with 3-vessel disease to undergo invasive coronary angiography in conjunction with CT coronary angiography with FFRCT, whereas the heart team decision did not show any difference. So in 93% of cases, the heart team decision in terms of 3-vessel disease was exactly the same as compared to invasive coronary angiography as compared to a CT-based coronary angiography. So we're now moving into an era where we no longer need to inject dye in contrast and puncture patients to see what their coronary angios look like and whether we should or should not perform intervention. So finally, I'd like to conclude with a little bit of my hobby. I'm an expert in chronic total occlusions. We know that chronic total occlusions happen in about 1 or 5 patients with obstructive coronary disease, and they tend to have a worse prognosis. And we know it's very difficult to predict whether they do or do not have success rate in terms of antegrade wire escalation, which is the mainstay in most of the centers in Europe and the United States. So it's very interesting that the score based on invasive coronary angiography can be mimicked by CT-based coronary angiography. And this is again work by Max Sapolsky, who shown us that you can mimic all these features like proximal cap ambiguity, lesion length, calcification, bending, and all these features that may or may not predict whether you're likely to open up the CTO artery. And actually, the CT-based angiography was more predictive than the invasive angio-based anatomy to predict whether or not the lesion could be opened. So this is not by say a need to know, but we know in Japan and the rest of the Asian world that basically everybody with the CTO procedure will now get one of these. This is an example. This is a CT-RECTOR score of 1. Maybe difficult to open, but very easily because the CT-RECTOR score is so low. And you easily open it. On the other hand, this is a CTO-RECTOR score of 4 based on the CT imaging. And now it's going to be more difficult to open up the artery. And you may refer this patient either to alternative forms of treatment, like bypass surgery, or referring to expert centers. Because these are the images that you obtain. Some things you cannot see by invasive coronary angiography, which you can see with CT-based angiography, like proximal clap, lesion length, distal target, etc. Also, nowadays we have the fusion imaging of the cath lab of CT-based coronary angiography, which we now fuse in the cath lab, which allows you to navigate your wire through the lesions, whether it be obstructive or non-obstructive. CT in the lab, it's something that the Koreans did back in 2013. I don't know whether that's going to be the new field, but it's something that's interesting when you can, sort of allocate your wire in the CT lab, even in a sort of hybrid approach. I just wanted to show you this slide. So what can CT do for you? It can identify you the lesion, CTO or otherwise. And it also can identify myocardial function, myocardial perfusion, and detection of myocardial scar. It can also show you the plaque features, lesion length, calcification, whether you need to do debulking, bifurcation lesion, etc. It can also show you that the angles that you need to take and the wires that you need to select may be more beneficial. And after the procedure is entered, in the years to come, you can do CT coronary angiography again to select stent patency or whether they did bypass surgery on graft patency. So long-term follow-up is important. So in the end, I'd like to conclude that CTCA can identify lesions and may assist in procedural planning. Virtual stenting is important. Plaque vulnerability is important. Chances of success in crossing the CTOs can be important. So I think we're moving into the field, whereas not only CT can identify coronary disease, but also can plan your procedure referring to a cath lab. But once you're in the cath lab, identify stent length and also even may predict whether you're not beneficial more with bypass surgery. Thank you.
Paul, thank you so much for that tour through how to, evaluate someone prior to the lab. So, here in the United States, we have, negative catheterization rates that are often greater than 50%, sometimes 70 or even 80%. So how often in your practice do you actually take somebody to the lab and decide to just do a diagnostic study and get out?
Well, that's obviously a very interesting question, because we know the Patel paper in the New England, like 10 years ago or something, that on average it's about 70% negative rate on invasive coronary angiography, and that needs to go up. I work at an academic site where we do stringent preemptive testing, whereas that number has gone tremendously down to about 20%. So it all depends on where you're working, what your cath lab and non-invasive environment is. But I think we have proven by now that if you have a solid program of non-invasive imaging, especially in conjunction with plaque features and perhaps FFRCT, that you would be able to bring that number down tremendously. Mm-hmm. On the other hand, I cannot judge for sites who don't, have that kind of facilities. So those numbers will still be 70%. So it all depends on your level of expertise. On the other hand, I'm an interventional cardiologist myself. I'm not that worried about a negative invasive coronary angiogram. On the other hand, for the patient, it's not good practice. I think it's a rather poor practice if you bring a patient to the cath lab and he doesn't have obstructive disease, because then something in the pre-test likelihood or the pre-imaging assessment, something has gone wrong. I only want to see my patients in the cath lab if they have obstructive coronary disease. Certainly.
And then you're unquestionably a master of all these non-invasive imaging modalities, MR, PET, SPECT, CT. What percentage of the people that you take to the lab actually have had a CT, or will you take somebody based on, perfusion imaging without actually getting an anatomical study in addition to that prior to going to the lab?
Yeah, so that's basically the referral pattern is based on the cardiologist at hand. So I don't necessarily condone it, but I've run multiple trials, and hopefully the Pacific 2 trial will be published in European Heart on very short term. In patients with previous known coronary disease who return with chest pain symptoms, where we know that functional imaging is very poor discriminator of whether they do or do not have obstructive coronary disease based on fractional flow reserve. So I think we need to move ahead. We need to have better imaging modalities to screen these patients. And I do think that CT-based imaging is the imaging modality of choice, not only for patients without known coronary disease, but we're now moving into the field of, moving into patients with known coronary disease, because we know that non-invasive functional tests are failing us. I do think that they're a good discriminator in terms of prognosis, but we also know that stable coronary disease is not as much about prognosis as it is about symptom relief and better quality of life in terms of if you want to send them to the cath lab and have revascularization. Right. So to come back to your question, I think functional imaging has a role, but it's diminishing, and anatomical non-invasive imaging is increasing not only in the patients without known coronary disease, but also with known coronary disease.
Understand. Well, one question we have from the audience is in regard to the new chest pain guidelines that were just released in the US this past week, specifically with the use of FFRCT. And I'll paraphrase it a little bit, but we do know that at times FFRCT itself has some issues with accuracy, sort of right at the 0.7, 0.8 range. And, you know, is that, you know, and so folks have used that to, you know, make some alternative approaches potentially, or question its role in that area. When you see somebody like that, if the FFRCT value is borderline, how do you handle that? Do you bring in other plaque features that you can see on the CT itself to try to decide what to do, or what do you do in those situations, knowing that there is somewhat of that limitation?
Yeah, it's a very interesting question, but you know, as with anything, FFR itself is obviously a continuous scale. It's not a dichotomous something. It's not like FFR is going to be different between 0.81 and 0.79. So you need to think about the fact of the coronary anatomy if you're going to be able to increase the FFR in a significant number. And you can do that based on CT imaging, but also in the cath lab with FFR pullbacks, IFR pullbacks. It's got to do with the anatomy. And sometimes you have an FFR that's clearly below the threshold, but a stent won't alleviate the FFR and thus the symptoms. But you can also predict that with CT. So to come back to that issue, I don't think we need to focus on whether an FFRCT is going to be 0.81 or 0.79. We need to focus on whether or not we can treat the patient and whether or not we can place a stent or do bypass surgery, which is going to alleviate them of their symptoms. Because a lot of these patients may be better off without any treatment, just by medical treatment alone. So it's a very difficult question, but it just adds to the insights that we have, that we should not focus just on FFRCT and in the borderline. Borderline means you have some sort of obstructive disease, but how to treat is a different question. And CT is not going to answer that. FFR is not going to answer that. It's simply talking to the patient and whether or not the stent will alleviate your symptoms.
And actually that leads into my next question nicely. So if you have a patient with an anatomic obstruction and you do see that if you use the FFRCT as one of your pieces to guide you, how about the atherosclerotic plaque features of the lesion itself? I mean, is that something that you can then use to decide, do you do atherectomies? Do you decide what type or size or length stent that you would choose based on whether it's a calcified or non-calcified, or maybe even a very low density plaque? How do those play into your decision tree prior to intervention? Well,
to talk to your last sort of comments about calcification, I basically, if the balloon cracks the plaque, it's sufficient, and I don't need a CT for that. But what's most important thing is if you have like a non-calcified plaque, because we do believe that those are more likely to produce myocardial infarction in the future if you don't treat them, if you don't preemptive stent them. So in my personal practice, I am more likely to stent a non-calcified plaque than a calcified plaque with the same hemodynamic significance, predominantly if they're non-significant based on FFR. But this is unproven medicine. But we do know from all the papers of Jagat Narula that obviously that non-calcified plaques are more prone to rupture. But this is a field of expertise that we do not know. But in clinical practice, we do see that this influences our behavior. If we see a young person with a non-calcified plaque, which may or may not be on the threshold of FFR significance, we are more likely to treat than we do not. So this question is highly relevant, but I cannot answer it.
And then for those, when you do see those high-risk plaque features, do you also concurrently treat the patient medically different after the procedure or prior to the procedure?
Yeah, so we know one of the driving decisions makers, for example, in the Scott-Hart trial, was based on the fact that, well, Scott-Hart trial is a little bit of a difficult trial to interpret because some might call the non-CT arm the neglect arm, and some might call the CT arm the intensive arm. But these patients were highly aware of the fact that they had coronary disease. And then they changed their lifestyle and then they changed their medical regime based on the fact that they knew that they were having underlying disease. Yes, I see that on a daily basis, that based on CT imaging, we highly intensify medical treatment because, as Jim Min has shown us in confirm and whatever, if you have a calcium score of 0 and no plaque, statin therapy is useless. But if you do have coronary disease, even if you do not have obstructive disease, statin therapy is useful. So it's a good selection criteria. So that's why I'm a highly proponent of CT coronary angiography in symptomatic patients, even if they don't finally end up with, you know, obstructive coronary disease. It does give you a good selection criteria whether you should or should not treat your patients with more intensive therapy. And I just got a question whether we should, you know, go to a more aggressive with like a PCSK9 therapy. I don't know. I'm not a lipid expert, but I do know that CT coronary angiography gives you the morphology and plaque characteristics of what you have. And if you do not have coronary disease based on coronary 0 and no plaques, statins are useless and you should not be taken.
Yeah, and we now also have the ability, as Matt Budoff had done in one of the prior webinars, to see the efficacy of that therapy. If you have a patient you have on CT and then you treat them with one of these more aggressive medications, you can then look down the road and see, using quantitative methods, whether you're getting, you know, stabilization or even regression of the plaque, or whether it's continued to progress during that period of time, which may then push you to be, you know, to change the medication regimen. So we do have some options prior to intervention in terms of being more specific in the therapy that we're giving, and then also knowing whether that therapy is actually successful, because previously we haven't been able to do that or to track it. So Paul, I think we've answered the questions, and thank you so much for your time. We're going to take a few minutes and look at a few cases, but we're very grateful for your lecture, and thank you for your sharing your expertise with us today.
Yeah, I would like to add one more comment to everybody who's watching, you know, because if you could also alter your plaque by lifestyle modification. We know that, for example, that if you do endurance training, you can modify your soft plaque into a calcified plaque. So calcified plaques doesn't necessarily mean it's a bad thing. It just stabilizes the plaque that was already there. And statin therapy sort of does the same thing, but it's very important to know that for people, not just for physicians, but also maybe the laymen who are watching, that calcified plaques are not necessarily bad, it's just aging process. But stabilizing the plaque may be of more importance.
Yes, absolutely. And certainly diet has also been shown through some trials now to produce favorable plaque changes with, you know, reduction of the low density plaque and transformation of the existing non-calcified plaque into calcified plaque. So yeah, there's a lot of other options available short of medications. And in the medication realm, we have many more medications now that actually also show favorable plaque changes than simply statins. So we have people have a lot of options available. So again, thank you again, Paul.
Okay.
So for everybody else, I'm going to swap over and share my screen. For those of you who have signed up, you can do the same and get into our library of cases. We'll look at a few here that will hopefully demonstrate some of the things that we talked about today. The first one I'm going to choose is this one. It's on the first page, 717 CDD61. Just by clicking anywhere on the line, not on the blue one, we can launch into the Clearly Labs, which is our it's sort of the imaging, the plaque imaging software. Once a study is uploaded to the cloud and goes through our, we have 8 different machine learned algorithms that will go through and select the most optimal 2 series to evaluate. It'll then do a center line analysis of all the vessels. It will then determine the lumen boundary as well as the outer wall boundary, and then we'll go through and look at stenoses. Everything between the boundaries is then considered atherosclerotic plaque, which is then characterized based on its Hounsfield attenuation. So the process generally takes about 7 or 8 minutes. I apologize, mine seems to be loading up a little bit slower today than usual. But that's the the process. Paul talked a little bit today about the rejection rate for FFRCT, which is sort of a binary thing. They either will reject the study or they'll perform the study. We have a little bit of a different algorithm in that we generally accept all studies. We don't actually reject any studies, but we will exclude certain parts of the study if we feel that the artery has a significant amount of motion or the segment or portion of the segment. It tends not to be a lot. Looking at a recent large-scale trial, we only excluded about 1.3% of the coronary length using that modality. So rather than rejecting the study as a whole, we may, if we do reject anything, which is we reject things in less than half the cases, we'll reject just a short segment. So in this case, we'll come in sort of more traditional imaging, curved planar reformats, which we can run around here. In this case, I'm going to hop over to the LAD, and here we can see that we do have a fair amount of atherosclerosis in the proximal portion of the LAD here. The purple line is the lumen wall boundary, and then the yellow line is the outer boundary that connotes the outer wall, or the EEM if you're an IVUS person. For the study. And here we can see a large and complex plaque. It's predominantly calcified, but not all calcified. As I hit the letter P, or you hit this red thing here, you can sort of turn the colorization tool on. So, and I'll mag up the short axis. So I'll put my cursor up here at the very beginning. We can sort of walk through this plaque. You can see we're here in the left main. We do have some left main plaque, predominantly calcified. So as Paul had said, certainly a better situation than having a very a non-calcified or maybe a low density plaque in that location. As we go further down the LAD, you can really get an appreciation for the eccentricity of these plaques. It can sort of flatten the lumen there. This plaque is certainly, the majority of it is calcified in this situation. So probably the risk to the patient from this particular plaque is going to be lower than it is for other types of plaque that are out there. They do have a much tighter calcified plaque in the RCA. In this case, if we look down here in the mid RCA, we see a predominantly calcified plaque that is very short segment, little higher stenosis that goes along with it. We just had the Clarify 2 study accepted at JACC Imaging, in which we compared 300 patients with quantitative coronary angiography as well as FFR. And what we did find with it, that our ability to use machine learning for the issue of stenosis specifically actually really helps us in terms of overall accuracy. And Paul showed some of the studies, early studies that showed specificities for coronary CT in the 60 or lower 70% range. Using our machine learning tools, we were able to actually elevate that. We still had excellent sensitivity, 90 to 94% compared to quantitative coronary angiography, but the specificity was elevated up to the 80 to 90% range. So we overcall fewer lesions, certainly than clinical readers have in the past, even expert clinical readers. And so that can really improve the overall accuracy of interpretation of CT. And of course, we're not just a stenosis-based tool. We will give you all of the plaque volumes. If we jump over here to the coronary report on this particular patient, we can see that we'll report out the entire plaque volume, the total plaque volume, which is 440 cubic millimeters in this patient, of which 270 are calcified and 170 is non-calcified. That's actually a fairly favorable ratio. You know, we never see anybody who's purely calcified, although we do certainly see people who are predominantly non-calcified plaque. And then on our platform, you can jump over and get a lot more granular detail on what segments are involved with the plaques, the total volumes of calcified plaque. And in this patient, the actual amount of the lowest density, which is the riskiest plaque, the low density non-calcified plaque, is quite low at 2.7 cubic millimeters. So this particular patient, born in 1954, so is close to, I guess, 70 years old. You know, this is a fair amount of plaque for someone in that age group, but of course, people get more plaque as they do get older. Good news for him was really no significant stenoses, and more of the plaque was calcified, which connotes less risk to the patient. We know the denser the calcified plaque is, that the densest plaque, which have calcification, which have Hounsfield attenuations of over 1,000, actually have very little risk and may even be somewhat protective by sort of, you know, keeping the vessel sort of with a rigid lattice, perhaps. And he is, you know, just a tiny amount of that lowest density plaque. Michelle Williams has done some work with the studies to show that that low density plaque is, without question, the riskiest plaque that's out there. The other, you know, things that we do with on our study, if you go back to the initial page here, we also have patient-facing clinical reports. So in this case, if we click on this here, I can bring up, we have a patient report that is made specifically for the patient and patient interaction. So this is something you can share with the patient. They get, their name goes on it. Obviously, this is an anonymized report. It will have a lot of information about coronary atherosclerosis, coronary imaging, what does a CT do, what are different types of plaque, and what risk do they connote to you. And then there's also, you know, the pictures of their vessels themselves with the color overlay, so they can actually see, you know, where their plaques are, you know, what stenoses may be present, and then what type of plaques may be there too. So this is something that a lot of our referring physicians have said can really give a very powerful interaction with their patients in terms of getting people to be more adherent to, you know, their lifestyle changes or medications that are being prescribed based on the study itself, that, you know, they can bring this home, put it on the refrigerator, share it with their loved ones, et cetera. So rather than relying on, you know, a very verbally dense, you know, medical report that's really not intended for the patients to use, for all of our analyses, we do provide these patient-facing reports that then they can use and, you know, take home and, you know, hopefully be a little bit more adherent to either their medications or to whatever lifestyle changes the provider may be, you know, giving to them. We'll take a look at another case here. This would be FBA65. It's the third one from the bottom down here. This is a patient really with a profound amount of plaque. It's a little bit of an unusual case in that the amount of non-calcified plaque here is really at the highest percentile in terms of studies that we routinely see. And it's of interest because it has doesn't have as much luminal stenosis associated with it. So I think certainly this patient would unquestionably fly by a functional test without showing any ischemia. If you were just looking, you know, at the lumen on a study, you would also say that I think they're a CAD-RADS 2 category. But once you start looking at the amount of plaque that is present on this study, realizing that the volume of plaque and the type of plaques really are the strongest predictor of future events, you really need to classify this patient into a classification that, using other non-invasive modalities, you would not be able to do. So we'll take a peek here as it comes up. Again, if we look at this, right coronary artery using sort of traditional curved reformat, we see a little bit of a narrowing here in the proximal, RCA. But then as we actually go through and we analyze exactly how much plaque is there, you can see there's really a long segment of tremendous positive remodeling here in the proximal portion of the vessel. We do see a little bit of calcified plaque here, but the predominant amount of it is non-calcified. When we eyeball that, you can see, well, it's fairly low density. And then when we do our color plaque overlay, you can see that most of it is red. So our convention at Clearly is that when we color code plaques, blue plaques, as you see down here, are calcified plaques. Yellow are either fibro or fibrofatty plaques, so they're the sort of the standard non-calcified plaque, but red is the lowest attenuation plaque that really, in terms of the patient, connotes the highest risk. So certainly this may be one of those cases, as Paul was saying, if he had other reasons for stenting this vessel or maybe was on the borderline of it. I don't think this is actually, this actually we're getting a 67% narrowing. So probably this, it's borderline for stenting, but certainly if you want to stent, if you're going to be a little bit aggressive about stenting a lesion, this is probably one of those lesions that he was discussing because, based on the atherosclerotic plaque features here, this puts the patient at fairly high risk. If we jump over here and look at his coronary tree, looks like maybe he's got a codominant, circulation with the most of the PDA coming off the right side, but there's a big distal circ over there also. But this is certainly a plaque that really places this patient at significant risk, despite the fact that it has a borderline stenosis. This is a plaque that would probably, really benefit the patient to be intervened upon. And then he also has a left main LAD plaque, which is of interest here too. Really very different phenotype. So in the same patient, we had that plaque in the RCA that was predominantly low density non-calcified plaque. But then when you come over here and look at the left main LAD, the patient has a plaque which is predominantly calcified plaque. Over here on the right-hand side, we have some of our numbers, 428 cubic millimeters of total plaque, but more than half of it is actually calcified plaque. So it's really interesting to me that he has two very different looking plaques, both with significant atherosclerosis, in the same patient. We don't always get the same phenotype in each of the vessels. The vessels can have some of their own, different appearance, and that, which of course may be used differently. So that's it, I think, for today. I'd like to thank Paul, Dr. Knaapen today for his very informed and educational lecture. I'd like to thank the Society of Cardiac CT as well as the American Society of Preventive Cardiology for co-sponsoring this series with us. Each of the 4 videos will be on their websites, and Clearly we'll also be posting the videos on our websites if you want to view them later or share them with some of your colleagues going forward. My email is james.earls@clearlyhealth.com, and if you have any questions, we'd be happy to handle it. Thank you again for your participation in our series, and I hope that this, this new information and the new ability to be able to non-invasively get so much more out of CT, and increase specificity for stenoses, as well as a way to quantify the amount of atherosclerotic plaque, as well as determine whether there's adverse plaque features that are there. We hope that this is something that may be useful for you in your clinical practices. If this is something you would like to pursue, have a research interest in pursuing, certainly we are eager to partner with sites interested in using us. There's many clinical questions out there that have yet to be answered, and so we would love to participate in that process. But thank you all, and have a nice day.